All right, guys watching, welcome to GAN. This is me with Linda Bells looking at a polyp in the transverse colon. Yeah.
Yeah.
So we'll talk to you about assessment, we'll talk to you about resectability, we'll talk to you about competencies, and we'll talk to you about, we'll show you a little bit about doing it. So your blink, Lynn, your first impression?
No mucosal invasion from me,
And okay.
but like good blink.
Okay, and then let's have a little bit of better look at it. So Lynn's going to look at it with white light. She's going to go round it with near focus. She's going to do it in narrow band to show you how we're doing it and really look at the back. CAP is really pretty useful for that, to get the back of this lesion shown. We were just, before we started this, retroflexing on it, but that doesn't show much of the lesion, and it's actually a difficult position, whether it's the scope or the patient's difficult to move. And we have maybe a minute of that so that we are really getting an idea. So what kind of, you're discovering anything with the white light near focus? Not really, eh? Not more than we didn't already know. What's that there at the bottom? Is that something off the polyp? Yeah, that.
It seems like chicken skin appearance, but not polyp, I think. No.
Not polyp, but also not really specific for anything, although
No.
potentially associated with the past with invasion. During the
Here.
colonoscope controls.
Yeah.
Okay. And I mean, it's not a great place to freeze it on. Let's freeze it on a more standard place so that we can talk about the pit pattern of this. Okay, there maybe. So what do you think? I mean, we can't see pits, we can see vessels, kind of the inverse of pits, but what do you think about that? Sort of pit pattern have we got
It's
there?
a regular pit pattern, kudo 4.
Okay, so I agree with you. It's regular. It's not kudo 4. It's almost certainly kudo 3, and it's maybe 3 long or 3 short, combination of the two. But kudo we shouldn't really talk about with
And
virtual
BI.
colonoscopy. We should talk about JNet.
JNet.
And so what is your JNet here?
2A.
2A. JNet 2A, nice 2. And so I think it's just down at the bottom.
This is the placement, yeah.
Possibly, not convinced. Yeah, now, yeah, for sure. And then freeze it when you can see something, maybe a little bit less bubbles on the image. Okay, all right, what do we think about that now? Is there something to be worried about, or you think it's JNet 2B?
Could be the 2B. It's different from the rest of the polyp pattern. But it's still some regularity in.
Could it be a biopsy site?
I don't think they biopsied it. But
Okay, so is this changing your decision making? Because we didn't find a demarcation zone, unless you call this a demarcation zone. But I think when we're talking about this sort of thing, this has to be in the category of demarcation zone. This is not the morphology, this is not the size part. So we're still looking, for me, for a demarcation zone. If this is a demarcation zone, then what are we going to do? We're going to just cut this off with EMR now? Or that's the question.
That could change our opinion in doing ESD maybe, or even.
Right. So what are we going to do? It comes down to what we think this is, and I think that in non-granular polyps, you have areas like this of change to 3S from 3L. So if you back off it now and just show the rest of the pit pattern of it, probably what we're seeing here is clearly within a non-granular polyp, we're seeing different types of the tubular pit pattern. So we're seeing 3L and we're seeing 3S. But really, are we seeing significant irregularity here? I don't think we are. So given that this is now we're going to switch to our +3 thing, Paris 02A, right? Of what, 25, 30 millimeters in size, right colon location. non-granular, in a relatively comorbid patient. For me, this is for piecemealing, not for ESD. But ESD would be difficult here. So low covert risk, no overt risk. And then the last thing?
Is, do we need to clip this?
Do we need to clip it or not? So what's making that decision for you?
So the patient.
So evidence-based answer,
right,
yeah, exactly.
colon.
Yeah. Size of polyp.
Yeah.
So how big was it? 25 maybe, maximum 20 maybe even. It's a comorbid patient. It's a patient not on antico, and it's in the right colon. So, yeah, I think you can. I mean, for me, it's like there's two things. One, the risk to the patient of having a bleed, and two, the complexity of the procedure that's required to solve it if it bleeds. Number one here, I think we should do it for number one alone. And number two, I think it's not so complex, so we're going to do it for number one, which is location and risk to the patient.
So what I mean is there are some principles, right? There's the fan principle. So the principle that bleeding is normally coming from an apex of a fan. So the bleeding point is probably here, where you've just coagulated, but you need to be more precise because you obviously just went too much to the left of it and not onto it. There's also the fact that you're intermittently using the tip versus the middle of the tip, right? And you need to use the tip with pressure rather than this part of it here. Yeah. I mean, I think if you were to ask me what was good, already what was good is your tip control. Already what was good was your snare positioning is already quite good. But to summarize in one thing, what you can do better, it's knowledge, it's experience, and that's for everybody out there who is watching these things. What you can really gain from these is knowledge and experience, right? And you can't gain the practical skills. And Lynn's lucky enough to have great practical tip control and skills and hand-eye coordination, but maybe that's something you need to practice more. But you can learn the sort of things that Lynn was learning here, which is you were learning new techniques to deal with bleeding, how to identify where the bleeding is coming from, precisely how to treat it. There's a vessel go along it, how to clip in the kernel. All that you can learn from a video. You don't need to learn that in an endoscopy room. And so what you particularly personally can do better is precision. And it's not that you can't do it. It's that you just need to realize that it's all about precision, and it's all about, like, the patient outcome at the end of the day is all about doing it precise.